All right, Karen. Dr. Chronicles, go.
Theo, this week I had a young gentleman. He was 23 years old. He came in. Now, as one of my roles is when people come into hospital, so they can walk into A&E or they can come by obviously an ambulance. I don't get involved in the ambulance side, but the walk-ins are kind of my, bread and butter. And the first thing we need to do is obviously make sure we are allocating the right resource. What that means is asking the question, do you need to be in hospital, right? If you do need to be in hospital, who needs to see you? Is it an A&E doctor needs to see you? Does a specialty doctor need to see you? Can a GP see you? When I say GP, not talking about their normal GP. We have GPs on site, and we have lots of other kind of supporting services. This is all the stuff that Sanj talks about as well. And so generally, when the names pop up on the screen, and it's a younger person, generally we will stereotype to think that actually if it's a younger person, probably not going to have anything wrong with them. Obviously, an elderly person is much more likely to have something wrong with them.
Yeah.
Part of what I do is when the nurses are doing a triage. So triage is when they take the observations to check are they very, very unwell based on their numbers as parameters, and obviously have a little bit of the story about why you're here essentially.
Mm-hmm.
I on the other side will be essentially stalking them, looking up all their medical letters, why they've come before, trying to get a paint picture of who's this person. Obviously, somebody's got no medical records is obviously a lot healthier generally. Okay, not always the case. And somebody who's got lots and lots of letters, we can kind of start to build a story. A lot of people often present with the same thing again and again, so it gives us clues in that sense and blah, blah, blah. So this young 23-year-old had loads of letters from cardiology, so heart specialty. And then so I started reading about him, and I was like, okay, this dude's, he's not like someone I can just say, yeah, you don't need to be here. I will really need to think about what we should do with him. So he has a condition called an AVRT. And AVRT stands for atrioventricular, I say RT, AVNT, sorry, not RT, AVNT, atrioventricular nodal tachycardia, reentrant tachycardia, okay? And basically what that means is your heart has 4 chambers, to the top, to the bottom, okay? And there is a set pathway of electricity that passes. That means that the top contract, pump blood into the bottom, and then the bottom contract and pump blood to the rest of your body.
Yeah.
That's normally how the heart works. So it's 1 2 1 2 1 2, and then obviously you get the dub 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 dub, which is the heart sounds, which is the valves closing. That's where you get those sounds. So there's a given set pathway for electricity, but there are conditions where you get what we call an accessory pathway. So outside the normal path of electricity, you can have another pathway which is unregulated. And because unregulated, not governed, very, very dangerous because the heart can go berserk. So, for example, the reason why your average heart rate is 72 beats a minute, what we quote, is because this electrical pathway has pauses and blocks built in that mean it doesn't go like 400 beats a minute. It's all designed specifically that way, right? But this other pathway, unregulated, okay, so which means it can just do whatever it wants. There's no checks, there's no nothing. So he had another pathway on the side. And the thing, when they say electricity will take the path of least resistance, or water will take the path of least resistance, that's exactly what happens again with the heart. So if the heart has a chance to jump on this other pathway, it's unregulated, it's like, yep, I'm not going down this one. This one's got too many blocks and stops. I'm going to go down this one. And so this dude, when his heart goes into that pathway, it goes faster and faster and faster and go berserk. So his heart could go up to 170, 180, 200, 250 beats a minute.
Jesus.
Yeah.
Without any exercise?
Yeah, he's like, he could just be sitting there and go, psh. So this is old, so we knew about this already, and he'd had an operation which is called an ablation. An ablation is where we burn that pathway. So they go in, they isolate where that, what we call the aberrant pathway is, where the naughty pathway is. They isolate it and then they burn it. By burning it, you're then saying, you're forcing the heart to go back to the normal pathway. So he'd had the ablation. That was earlier this year. And he'd come in, he said, oh, Jazz, it's about 3 o'clock in the morning. I was about to go to sleep, and I just felt some palpitations. That's when your heart races like boom, 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 boom. And I was like, okay, fine. So when everyone tells me, they got palpitations, my question generally is, were you doing something when they happened, or were you just completely at rest? In general, a palpitation that comes on with exertion, with exercise, is generally considered more dangerous, and I'll touch upon that in a second. And the second thing is, did you pass out or feel like you're going to pass out? If your heart rate goes fast enough, okay, what happens is your heart does not have enough time to fill properly. If your heart doesn't fill properly, there's not enough blood that comes out of the heart. Blood pressure is determined by how much blood that comes out of the heart, okay? So if you haven't got enough blood coming out of the heart, blood pressure is low. If there's not enough blood going to your brain, you pass out. That's what fainting is, Okay. So if
Got
somebody
it.
says to me, actually, when my heart goes really quick, I feel dizzy, like I'm going to pass out. That's a concern. I'm like, oh, okay, this is something we need to sort out. Okay, because there are a lot of people who can have palpitations like after coffee or Red Bull, and it's not that concerning, and they're fine, and it settles on its own. So that's and the third question is, so how long did it last? And he goes, well, normally, they last about 5 minutes, and they go away on their own. I'm not concerned. He was like, this went on for 2 hours. I was like, oh shit, that's quite a lot. And I said, have you got them now? And he said, no, I haven't got them now. And then we did the ECG, which is the recording of the heart when you put the stickers on the chest. And at that point, when he's sitting right in front of me, he wasn't in the funny rhythm, so the ECG looked completely normal, but it's not the whole story, right? Obviously, the ECG is only as good as when we, at that moment, in that second, it will capture what's in that second. If you're not having the symptom, if you haven't got the fluttering of the heart, then it's not going to capture anything. He had what we call an ILR, implantable loop recorder. So it's a little device about this big. We put it under the skin. It can live there for years. So he'd had it for 6 years. And essentially, it just records the heart, and then it gets recorded remotely. And then if he feels something, he can basically press a button, and then we will start
and say log it.
Yeah, exactly. Log it, and then it'll get looked at. And so, I rang my guys in cardiology. I said, look, I've got this kid here. He's got this, and this. He's had this. These symptoms are pretty concerning. Like, I need to know, can you interrogate the device? Which means, can you look at between 3 a.m. and 7 a.m.? Tell me what happened. Right, what's on the recording? And so they come back to me a few hours later. The patient's moved at this point, so I've got him to the right areas, but I'm still following him up because I like to know what happens with my patients. And I'm like, yeah, Jazz, his heart went berserk, man. He went like to 222, and I was like, yo,
222 beats a minute.
Yeah, that's quick, man. And I was like, okay, like again, he's a young person.
What's the max a heart can go to?
That's a good question. Generally, what we get taught is it's 220 minus your age should be your maximum heart rate. Okay, so you can work out what yours is. Yeah, so his is going faster than that.
Yeah.
23. It's fast. You can't sustain that. Had he stayed in that, then the heart would just stop at some point. But he's been given a tablet which you can take when it goes a bit berserk, and he took that and looked like.
Can your heart explode? Is that possible?
Heart doesn't explode; it just stops.
Oh, mad. Okay.
So
wow.
Right. So, and the reason for that is, or you can have a heart attack as well. The heart gives blood to the rest of the body. Everyone knows that. The heart also gives blood to itself. That's what most people don't know. Right?
Yeah.
So if your heart rate goes fast, the filling time of the heart, so that's when the heart, remember that the heart has two functions. It fills and then it pumps. It fills and it pumps. If the filling time is reduced, there's no filling, then there's nothing to pump out, right? And we talked about blood pressure and feeling dizzy. But the other thing here is, in the filling phase of the heart is when the heart actually gives blood to itself. So if the filling time is reduced, the time that the heart has to give itself blood is reduced. If there's no blood going to the heart, that's what a heart attack is. That's exactly what a heart attack is. So yes, your heart can just stop. So yeah, so then we got him upstairs to the cardiology. We spoke to his consultant, and we tweaked his medicines. And now they're considering doing another ablation, another operation to burn one of those pathways. So that was a good learning point. And the point here was, again, a young person can obviously have serious medical issues. And on the face of it, although he looked well, the numbers are fine, the ECG was fine. Now, you've got to have what we call a high index of suspicion based on the questions you ask. So the story, there are things in the story which are concerning to me, even though he looked fine now, right? And it's those patients, it's not very easy. It's easier to take someone more seriously when they're ill right in front of you. Like your temperature is 40 degrees, your blood pressure is 70. Like, you're unwell. I can see you're unwell. And your numbers are telling me, they're validating you're unwell. It's when I've got a story. Remember, stories are subjective. So this all then depends on the quality of the question. Which questions are you asking? And that's why those things are really important. Now, something else which is really important. So there are patients who can have these palpitations and the heart goes fast, and they ask me, Jazz, what can I do at home? There are 3 things you can do at home, okay, to try and slow your heart rate down. So imagine, you've got your Apple Watch or your phone is telling you your heart rate's going fast, and you've got a medical condition that means that sometimes your heart rate goes fast. How can you lower it down? First thing is what we call a carotid massage. So in your neck, you've got this pulse, the carotid pulse, right?
Yeah.
Supplies the brain. What you want to do on one side, not both sides, one side, you just want to start. So find the pulse first, 2 fingers. Find the pulse, okay? And then start massaging it. Okay, that's the first thing. I'll explain how all these work in a second. So that's number 1. Second thing you can do is you can take an empty syringe. So I normally give patients a syringe before they go home. And I say on the end of it, just try and blow. So blow into the syringe. Second thing. Third thing is get anything cold from your freezer and stick it on the end of your nose. Very effective. People can do this at home. Everything we're trying to do is to increase what we call the vagal tone. So we have the vagus nerve, which decreases heart rate. So I'm trying to promote the activity of the vagus nerve. And those three things can do that. And what I'm trying to do therefore, if I increase the activity of the vagal nerve or the vagus tone, it will decrease heart rate. So you'll start dropping it. And sometimes it can be enough that you don't need to go to hospital. So those are three quick, easy things. Now, I'm not saying don't seek medical attention. I'm just saying this is something you could do in the meanwhile and still, call 111 or see your GP or whatever you need to do. But yeah, those are my three tips on if you have a fast heart rate.
So, thing on face,
Ice.
cold press
Something
on
cold.
face.
Yep. Nose.
Massage neck.
Nose specifically.
Yeah, nose.
Yeah.
Massage neck.
Hmm.
And what's the third one?
It's
Sorry,
called
yeah.
do
Yeah,
a
the third one.
Valsalva. Yeah, third one. So a Valsalva maneuver. That's what I was describing. So blowing. It's kind of like when you.
Blow into a
know-
bag.
No, not blowing to a bag. Like if you're trying to open your ears and they pop, and you do that
Oh yeah.
kind of forced. That's a Valsalva maneuver. You do that, and the syringe helps you do that. So that's really, really
But if
handy.
you don't have a syringe, you can just do the first.
Yeah, you
two.
do the other two. Yeah, absolutely, exactly. Simple things. This is without medication. The other learning point, guys, is chest pain, right? So everybody gets worried about chest pain, and you watch enough adverts, they'll tell you chest pain, call 999, could be a heart attack. True, but not every chest pain is a heart attack, okay? So the things to worry about, if you think you're having a heart attack or you think you're developing angina, which is the medical word for chest pain, which is caused by blockage in the heart, then we will always ask you, are your symptoms exertional? Okay, so if you came in today and you said, oh yeah, I'm having chest pain, I'll say, okay, fine. So have you been having this chest pain before today? That's the first thing. You can have a random heart attack, but most likely you've been having symptoms that are building up, right? And then I'll always say to you, right, this is my key question. What is your main form of exercise? You'll always hear me asking this, and they'll say, okay, I walk. I say, right, do you walk every day? And say, yeah, I walk every day, or 3 times a week, whatever it is. When you walk, how long do you walk for? 30 minutes. Okay. When you are walking for 30 minutes, 3 times a week for the last 1 month, during the walking, does it bring on chest pain? This is the key question. So I'm trying to elicit whether the exertion is bringing on the pain. And then if you say, yes, actually it does, then I'll say, okay, if you stop, does the pain go away? So I'm trying to see, is it relieved by rest? Okay. So these I'm trying to work out, because I know there's loads of different causes of chest pain, things that don't worry me. So like muscular chest pain, acid reflux, inflammation, they're fine. They don't need emergency care. But if I'm trying to work out, well, is this coming from your heart? These are the things, guys. So if you're having pain like this, this is the time when you should be seeing your doctor. Like I had a guy on a couple of days ago, who again is quite young, and he's 45 years old. Has already had 3 heart attacks, has 4 stents. 3 heart attacks, 4 stents. Asian guy, so not pre-diabetic, probably diabetic now. Probably got a genetic predisposition as well. Key thing though, he's a smoker. This is the problem, right? And the reason, guys, everyone who wonders why is smoking bad, and we all talk about lung cancer, this is why smoking is bad for your heart, okay? You have 3 vessels of the heart, what we call the coronary vessels, okay? These supply the heart. These are the ones that when you get a blockage, you get a heart attack. Now, when you start getting a blockage in any of these arteries because of age or whatever it might be, okay, just natural stuff, not anything else, your body's very clever. What it will do is, if the blockage is this bit here in my finger, the vessel in your body will build a little bypass of its own. It will try and bypass the blockage. A new vessel will form.
Jeez.
Okay? When you smoke, you switch off the production of that new vessel formation. That's the first thing that smoking does. The second thing is the rate at which the blockage is occurring doubles, triples, much, much faster. That's why smoking is doubly bad. The rate at which you're getting a blockage in the vessel is accelerated. And what your body would do to combat that with the bypass, these other vessels that come around the outside, turns off the production. It is a killer. I said to this guy, stop smoking. Like, that is the single biggest intervention. You're on all these medications or whatever, but stop smoking.
Is it the fumes that are causing that, or is it nicotine and everything else? What actually is it?
The tobacco. It's just
the tobacco itself.
Yeah. It's the plaque which is forming inside the vessel, what we call atherosclerosis, the buildup of the plaque. It's contributing to that at an abnormal rate.
Wow, that's mad.
There you go.
Well, there you go, man.
There you go.
Signs for chest pain.
Signs
Cheers,
of
doctor.
chest pain. Yeah, thank you.
Next segment.